Hi, this case study and presentation is on cirrhosis by Christine Batone, Elizabeth Jackson, and Aaron Prescott.
Clinical presentation. SG is a 46-year-old white male who presents to the outpatient clinic with his wife. The chief complaint, as per SG's wife, is, "My husband is confused, is acting strangely, is forgetful, his abdomen is swelling again, and his cirrhosis seems to be getting worse." Past medical history includes alcohol-related cirrhosis, uncontrolled ascites, peripheral edema, upper GI hemorrhages related to esophageal varices, anemia, peritonitis, pneumonia, and acute pancreatitis. SG lives with his wife and has been a department store manager and salesman for the past 17 years. He's a former half-pack per day smoker for many years, has a history of alcohol abuse, of 3 cases of beer per week for 15 years, and he quit about 5 years ago, following a motor vehicle accident. He also has a history of IV drug abuse, of heroin, and intranasal cocaine abuse, and quit 5 years ago. His father died at age 52 from liver disease. His mother died of a stroke at age 66. His maternal aunt is still living, and she has Graves' disease. Signs and symptoms are increasing abdominal swelling, confusion, irritability, and forgetfulness over the past month, lethargy over the past 3 days, and unintentional weight gain of 15 pounds over the past 4 weeks. Pathogenesis. The liver plays a crucial role as it metabolizes protein, fat, and carbohydrates, all necessary nutrients for the body's proper function. The liver can weigh between 1.3 and 1.8 kilograms and functions as the largest gland in the body, holding approximately 13% of the body's blood supply. The main functions of the liver are bile formation, cholesterol and lipid metabolism, drug metabolism, carbohydrate, fatty acid, and ammonia metabolism, protein synthesis, storage of iron, fat, glycogen, and vitamins, phagocytosis of bacteria, hormone and steroid catabolism, heat production, and synthesis of clotting factors. Cirrhosis is a condition that is caused from irreversible scarring and damage of the liver. While the liver has the ability to regenerate or repair itself, the continuous process of inflammation and repair causes scarring to occur. This scarring or fibrosis of the liver disrupts blood flow through the liver, creating a host of issues. Cirrhosis usually occurs progressively over the course of several years, and the severity and progression are related to the cause. There are many different factors that cause cirrhosis of the liver. In Western countries, the most common causes are chronic alcoholic liver disease, chronic Hep C, chronic Hep B, and non-alcoholic fatty liver disease. In this case study, SG's cirrhosis is caused by long-term alcohol abuse. The exact pathophysiologic mechanisms of cirrhosis are still not completely understood, but there is a common knowledge of the molecular pathway. The toxic effects of alcohol on SG's liver is caused by excessive amounts of acetaldehyde, leading to oxidative stress, lipid degradation, and disruption of proper liver cell functioning. There are also alterations in liver metabolism causing a disruption in protein transport and disruptions in the proper function of vitamins and minerals, leading to overall malnutrition. Alcohol can cause the gut to become more permeable, thus promoting gram-negative bacteria to grow in the intestine, increasing the level of endotoxins. The elevated endotoxin levels increase inflammation and add to the progressive damage of the liver. The common molecular pathways of cirrhosis involve non-parenchymal cell dysfunction, continuous damage to hepatocytes, inflammatory cytokines, and miRNAs. The non-parenchymal cells of the liver include hepatic stellate cells, or HSCs, liver sinusoidal cells, or LSECs, and Kupffer cells, or KCs. HSC's main function in their resting state is to store vitamin A and other vitamin A derivatives called retinoids. As HSCs are exposed to inflammatory cytokines, they become activated. This activation causes cells to rapidly multiply and transform into myoblasts. This causes excessive collagen production and deposits on the liver, leading to scarring. LSCs are the fenestrae or openings, whose function is to filter the exchange of fluids, solutes, and particles between the sinusoidal blood and the parenchymal cells. Over time, alcohol abuse can reduce the number of fenestrae, which decreases the ability for LSCs to filter properly. KCs are the macrophages that are in the lining of the liver sinusoids. Different factors can activate KCs, such as infections, alcohol, iron deposits, and fatty diet. When KCs are activated, they release harmful chemical mediators or messengers and activate HSCs, leading to an inflammatory response in the liver. The increased level of endotoxins during alcohol abuse also contributes to the activation of KCs. Parenchymal cells are the hepatocytes. These cells can regenerate or self-destruct. Damage to hepatocytes cause a release of chemically reactive molecules containing oxygen, which in high levels cause cell damage. Hepatocyte damage also causes a release of fibrogen mediators, which contribute to fibrosis and scar tissue. Damage to hepatocytes also activates HSCs and stimulates myofibroblasts. All of these reactions contribute to the inflammation and scarring of the liver. Inflammation plays a key role in the development of liver cirrhosis. Cytokines are an important factor in the signaling and activation of HSCs and liver fibrosis. These cytokines include platelet-derived growth factors, or PGDFs, transforming growth factor alpha, transforming growth factor beta, and interleukins, or ILs. When hepatocytes are exposed to alcohol, the KCs are signaled to release PGDF. PGDFs then activate HSCs, leading to the overproduction of collagen, causing hepatic fibrosis. TGF-alpha promotes inflammation, stimulates macrophages, activates HSCs, and can induce apoptosis. TGF-beta are the major contributor to collagen synthesis in the liver, leading to liver fibrosis. Clinical studies have shown that cytokines IL-1 and IL-2 and chemokine IL-8 are present in increased levels in patients with alcoholic liver disease. IL-1 and IL-2 are pro-inflammatory cytokines. Both can induce fever and act as mediators in the immune system. The presence of the IL-8 chemokine induces neutrophils to travel to the site of infection. Another contributor to cirrhosis is miRNAs, which are small non-coding RNAs. Studies have shown that certain miRNAs play a significant role in fibrogenesis of the liver. Excessive expression of these miRNAs causes an increase in the expression of genes associated with fibrosis that are present in HSCs. Studies now show that these miRNAs can act as biomarkers for patients with cirrhosis. As cirrhosis occurs, the fibrotic changes cause obstruction of the biliary blood flow, leading to portal hypertension and a decrease in blood flow of the hepatic arteries. Splanchnic vasodilation causes hypovolemia, driving sodium and water retention mediated by the renin-angiotensin system. Thus, the activation of the renin-angiotensin system causes vasoconstriction of the kidneys, leading to the increased risk of kidney injury. The pathogenesis of cirrhosis is multifactorial, and continued research will help to define more definitive mechanisms that are the cause.
Clinical manifestations. The signs and symptoms of cirrhosis worsen with disease progression. Early stages of the disease may be completely free from any symptomology. Neurological findings include weakness, fatigue, ataxia, and confusion. Skin findings include jaundice, icteric sclera, pruritus, spider angiomas, palmar erythema. Cardiovascular findings include portal hypertension, thrombocytopenia, anemia, and digital clubbing. Pulmonary, dyspnea, hyperventilation, and hypoxia. The body system with the most symptoms is gastrointestinal. These include ascites, gastric and esophageal varices, GI bleeds, hepatomegaly, splenomegaly. Genitourinary findings are hepatorenal syndrome, water retention, gynecomastia, and testicular atrophy. Common electrolyte imbalances are hyponatremia and hypokalemia.
Epidemiology. In the United States, cirrhosis is the 8th leading cause of death. According to 2016 data from the Centers of Disease Control and Prevention, The total disease mortality was 40,545. There were also approximately 12.5 deaths per a 100,000 population, conveying a mortality rate of 0.000125. To add, cirrhosis is the 12th leading cause of mortality worldwide. In addition, the 2016 incidence of the disease was approximately 4.9 million, which represents the number of adults diagnosed with the disease. For alcoholic cirrhosis, the incidence is the highest among middle-aged men, and SG is 46 years old. The prevalence rate, or the percent of adults with this disease diagnosis, is approximately 2%. To add, because cirrhosis marks irreversible damage, the mortality and morbidity rates increase exponentially when cirrhosis first develops. In this respect, comorbidities of the disease include the following: HIV, AIDS, liver disease, kidney disease, cancer, dementia, COPD, acute MI, CHF, in addition to other substance abuse disorders. Other comorbidities include hemiplegia, epilepsy, other central and/or peripheral nervous system abnormalities, malnutrition, as well as vitamin deficiencies. Muscle wasting caused by alcohol, myopathy, diabetes, and obesity are other comorbidities. Risk factors. In those with chronic alcohol consumption, malnutrition presents as an additional risk factor to the development of cirrhosis. Primary risk factors for developing cirrhosis include alcohol consumption, chronic hepatitis B, as well as chronic hepatitis C infection, NAFLD, and other metabolic liver diseases, primary sclerosing cholangitis and primary biliary cirrhosis, Wilson's disease, antitrypsin deficiency, as well as hereditary hemochromatosis. Other major risk factors are environmental contaminants, particularly those found in foods such as alpha-toxins, obesity, diabetes, tobacco use, as well as oral contraceptive use. The administration of certain medications that are hepatotoxic are additional risk factors.
Alcoholic cirrhosis begins with chronic alcohol consumption. Chronic ingestion of alcohol causes liver inflammation and fat deposition. This is how the first phase of cirrhosis begins: alcoholic fatty liver or steatosis. If the patient is able to stop drinking at this stage, the liver is able to heal itself, and many patients have complete resolution of symptoms. If drinking continues, the next stage is alcoholic hepatitis. The liver continues to have chronic inflammation along with fat deposits. The fat deposits increase to fat stranding, and hepatocyte necrosis begins. If patients are able to stop drinking at this stage, they can have some return of function, but there will always be permanent damage. The last stage is alcoholic cirrhosis. Hepatocyte necrosis with inflammation begin to cause scarring or fibrosis by way of excess collagen production. The scarring of the liver slows the liver's ability to metabolize proteins and enzymes. It obstructs biliary and vascular channels, and hepatocytes lose their ability to regenerate. Cirrhosis is permanent, but the disease progression can be slowed by abstaining from alcohol, even at this point.
Pertinent diagnostic and laboratory tests. Lab tests to order for SG suspected cirrhosis include the following: CMP or LFTs, because both tests include ALT, AST, and ALP, PT-INR to measure clotting factors, iron test for suspected hemochromatosis, and ceruloplasmin when Wilson's disease is expected. Abnormal test results indicate an alteration in SG's normal physiology and include the following: BUN 12, platelet 34,500, PT 15.6 seconds, PTT 45.1 seconds, ammonia 250, AST 107, ALT 86, ALP 224, bilirubin 2.4, albumin 2.7, alpha fetoprotein 90, anti-HCV is positive as well. Reasons for abnormal lab results. The low platelet level of 34,500 indicates an abnormal CBC result. In liver disease, there is decreased vitamin K absorption and thus an increased risk of bleeding. Thrombocytopenia occurs in advanced liver disease and is accompanied by altered hepatic biosynthesis. SG's low albumin level and elevated INR demonstrate that his hepatic biosynthesis is impaired. The low albumin level also illustrates the state of malnutrition characteristic to cirrhosis. To add, SG's PT-INR tests are abnormal. Prolonged coagulation often occurs with cirrhosis because most clotting factors are produced in the liver. To add, abnormal liver function tests, or LFTs, are exhibited with increased serum enzyme levels. For alanine aminotransferase, aspartate aminotransferase, as well as alkaline phosphatase. These tests are important for measuring the degree of liver stiffness. To add, bilirubin serum levels are also increased. Elevated bilirubin levels correspond to the impairment of the liver to detoxify substances. SG's decreased albumin serum levels and normal protein level are consistent with ascites. SG's anti-HCV reading of positive depicts a sudden progression of cirrhosis and his disease state. The lab tests also indicate liver cancer. In this respect, AFP is normally 15 or less. In SG's case, it is 90, which is very elevated. Ammonia levels are increased as well, which demonstrates late-stage cirrhosis with liver failure. Ammonia is a waste product that is normally metabolized by the liver, but with cirrhosis, ammonia serum levels rise as the liver cannot work to metabolize it.
Cirrhosis is a disease of the liver. In the case of SG, its cause is chronic alcohol consumption. Drinking alcohol frequently causes damage to your liver. The liver is the organ in your body that breaks down alcohol when you consume it. There are 3 phases to alcoholic cirrhosis. The first stage begins with inflammation or swelling of the liver. Alcohol causes the liver to become inflamed. If you stop drinking at this stage, the liver can heal itself and function can return to normal in many patients. The second stage is alcoholic fatty liver. In alcoholic fatty liver disease, the inflammation over time causes fat deposits. The liver becomes enlarged and stranded with fat. The fat interferes with the liver's functioning. If you are able to stop drinking at this point, the damage cannot be totally reversed, but some function can be improved. The last stage is alcoholic cirrhosis. This is when the fat and liver cells break down and eventually turn into scar tissue. Anywhere there is a scar and not undamaged liver cells, that portion of the liver can no longer do its job. So the more you drink, the more scars your liver has, and the less able it is to filter out your blood and keep you healthy. Cirrhosis is not reversible. If you're able to stop drinking at this stage, you may have some improvement, but you will always have liver damage. Patient and family education. The most important and primary treatment for a patient suffering from alcoholic cirrhosis is abstaining from alcohol. In the early stages of this disease, function can be returned if alcohol consumption is stopped. Even in the progressive stages of the disease, stopping alcohol consumption will increase longevity and quality of life. Patients and their families should be giving information to treatment centers and social work can help with determining eligibility and insurance costs. Alcoholics Anonymous has resources for patients and their families seeking help. AA and Al-Anon are free and nationwide. Also, if patients smoke, they should be told to quit. It increases their risk for hepatocarcinoma, a risk that has already been drastically increased because of the cirrhosis. There are usually diet modifications that need to be made. Small, frequent meals are preferred due to less gastric space from fluid accumulation in the abdomen. Patients with ascites should be placed on a low-sodium diet, usually 500 milligrams to 2 grams sodium restriction, and table salt should be completely avoided. Patients should eat a diet high in carbohydrates and high on protein. Unless they have elevated ammonia levels, then they should be on a low-protein diet with high carbs. Many patients with cirrhosis have malnutrition and may require supplements like Ensure, and they do make a low-protein option. Multivitamins, folate, and thiamine will generally be prescribed to increase availability and absorption. Patients that have significant ascites and also low sodium may also have a fluid restriction, commonly 1,000 to 1,500 milliliters per day. Patient and family education, secondary interventions. Medications. Drug therapy is a secondary intervention. Diuretics like Lasix and spironolactone are commonly prescribed to help with ascites and peripheral edema. Patients need to know to weigh themselves daily to determine if their diuretics are effective enough and to update the provider with weight gains or losses. Electrolyte imbalances can occur with diuretics, so patients should expect to get frequent lab work and possibly need a potassium supplement. Patients with portal hypertension, especially with gastric or esophageal varices, will be placed on a non-selective beta blocker. Propranolol is commonly prescribed, but Coreg is also now being used. Lactulose or Flagyl may be prescribed for treatment of high ammonia levels. Flagyl is an antibiotic. Lactulose is generally titrated for the number of bowel movements per day, approximately 3 to 5. Surgical treatments. Paracentesis is the treatment for ascites that is not responding or poorly responding to conservative management. The abdomen is cleansed and draped, and then a large bore needle is used to puncture the abdomen and a catheter is placed. The fluid is drained, usually by gravity. There is a maximum amount of fluid that can be drained at one time because of fluid and electrolyte shifts. They can cause arrhythmias and significant hypotension. Patients may have a paracentesis once or on a more frequent schedule. Variceal banding is also common. It is a treatment for esophageal and gastric varices. It is usually done endoscopically. Bands are placed over the prominent vessel, or they can be injected sclerotherapy. Treatment depends on location and severity. Tertiary interventions. A TIPS procedure is when an interventional radiologist enters the jugular vein to access the liver. A stent is placed to make a bridge or shunt between the portal and hepatic veins. This decreases the pressure in both the liver and the congested vascular system of the GI tract. The result is drastically reduced portal hypertension. But because a large amount of blood flow now bypasses the liver, this blood is not being filtered before returning to the systemic circuit. This can cause an increase in an already elevated ammonia level. Liver transplant. Liver transplants are for end-stage liver failure. Patients will need to get on with the transplant list. Patients will not be able to drink or use drugs for a minimum of 6 months before even being considered for transplant. They will need to take daily antiviral rejection drugs for life. It's a strict lifestyle and medication regimen. Is the patient anemic at this time? And if so, is the anemia normocytic, microcytic, or macrocytic? This patient is right on the edge of being anemic. The normal levels for hemoglobin and hematocrit for an adult male are between 14 and 18 and 40 and 54% respectively. If we were to classify this patient as anemic, then he would be normocytic. This is because his mean corpuscular volume is 90. The ranges for microcytic are less than 80 and macrocytic is greater than 100. Based on the laboratory data, why has this patient's cirrhosis shown a sudden and unexpected progression? This patient has a sudden and unexpected disease progression due to his hepatitis C infection. We can assume from his history of intravenous heroin abuse that he possibly contracted the infection before he quit using approximately 5 years ago. The patient has a very high viral load, explaining his current severe decompensation and progressing liver failure. On his labs, his HCV RNA load was 2.8 million. Why can bacterial peritonitis be ruled out as a current potential diagnosis? There are a few factors that allow us to rule out peritonitis. First, this patient has a normal white blood cell count. SG's white cell count is 4,700. Secondly, the patient does not have abdominal pain, rebound tenderness, or a rigid abdomen. Lastly, he does not have nausea, vomiting, or fever. Fever, abdominal pain, and elevated white cell count are key factors in diagnosing peritonitis. Which single laboratory test strongly suggests that the patient has developed hepatic encephalopathy? The single laboratory test that strongly suggests that this patient has developed hepatic encephalopathy is his ammonia level. A normal ammonia level for adults is between 15 and 60. This patient's ammonia level is incredibly high at 250. This makes a very strong case for his confusion and mental status changes being related to his liver failure. The patient's primary care provider has decided to conduct extensive clinical studies for the diagnosis of liver cancer. Which single abnormal laboratory value has raised concern that hepatocellular carcinoma may have developed? The single abnormal laboratory value that raises a concern for hepatocellular carcinoma is alpha fetoprotein. The AFP is a tumor marker, and this patient's AFP is 90. A normal level in adults is less than 10, suggesting he may have liver cancer.